Very good morning, ladies and gentlemen, to all of you for joining us here today, and a warm welcome to those of you following online streaming as well from across Europe who couldn't perhaps make it to Brussels today. It is lovely to see so many of you here in the room. Today, of course, we are going to be talking about decoding the European health data space and taking the perspective of doctors and patients particularly into account. It's a very timely moment. Data spaces is the buzz phrase here in Brussels. We're talking about it a lot, but when it comes to medical data, we all know how particularly sensitive it is. So, today's event, we're going to start with a keynote, and then we're going to have a panel discussion. The event, as you have heard, is going to be live streamed, but for those of you in the room here enjoying a breakfast, don't worry, you are not being filmed, you won't be on camera. There will be an opportunity towards the end to ask questions. We will have roving assistants with microphones, so your voice will be heard, but you still won't be on camera. But I do encourage you all to raise your hands if you've got questions. If you're sharing on social media, which we would love you to do, please do use the hashtag EHDS or hashtag eHealth. And of course, please do tag our organizations who are behind today's event, the KBV and the German Medical Association. And on Twitter, those hashtags are at KBV4, number 4, U, and BAEKAKTUELL. So use those if you're typing it in, and we would love to get more people involved in the conversation, particularly our audience watching online. It's a way for you to engage with our speakers. But with that, I'm going to hand over for our keynote and welcome to get us all started and set the scene here today to Dr. Klaus Reinhardt, President of GMA. Thank you, sir.
Yeah. Ladies and gentlemen, dear colleagues, thank you for joining us both in this room and online to discuss what is currently the talk of the town in Brussels health community, the European Health Data Space, or in short, the EHDS. I'm delighted to welcome such a distinguished audience, one that is already familiar with the Commission's proposal, so I will not have to overwhelm you with a detailed slideshow at such an early hour. This is not the first EHDS stakeholder event in Brussels, and even more have been announced, each focused on different aspects of this initiative. This morning, the German Medical Association, where I serve as president, and the KBV, German Outpatient Physicians and Psychotherapists, would like to focus on two contributors to the EHDS who are essential to its success: doctors and their patients. We have heard about the potentially great benefits that collecting and sharing health data can bring to healthcare and medical research. And I'm convinced that it is not only an opportunity, but our obligation to take advantage of the potential of health data. To do this, it's essential that we gain the trust of those who are responsible for bringing the EHDS to life on a daily basis. I'm trying to imagine a conversation between myself, a physician, and one of my patients in the near future. Today, if a worried patient asks me, "Doctor, can we keep this between us?" There's no easy answer. There's one easy answer. It's assured. Professional secrecy means that if my patient's husband calls and asks me whether his wife has been here and why, I cannot give him this information without her consent. But what if my patient has given her husband access to her EHR, the electronic health record, but asks me not to record one particular piece of information? This could be anything from an HIV test or hematoma suggesting domestic violence. Will I be obligated under the rules of the EHDS to record the information anyway, even against her will? Professional secrecy even means that if a policy walked in and asked me for information about a given consultation, I would ask them to leave empty-handed. How would my worried patient like the idea of knowing that the information she is about to confide in me will be recorded in her EHR and could potentially be accessed by anyone who has been granted a data permit? Yes, there will be an independent health data access body acting as a guardian and deciding whether the prospective user demonstrates a legitimate interest. But how should I explain to her that if this access body fails to make a decision, her data will be made available anyway without further assessment? How can I explain to her that there is no way for her to object? Will she find relief in that fact that her data will be used to foster innovation in health and that she might benefit from it one way or another? Or will she just leave my office? I really hope I will not have to have these conversations with any of my patients. There are many reasons why patients may not want to have a particular piece of information recorded or shared. Patients may be open to sharing the data with other healthcare providers, but not for secondary purposes. According to the Ipsos Global Trustworthiness Index 2022, doctors are considered the most trusted profession, with 59% of respondents rating them as trustworthy. Politicians landed at the other end of the scale, achieving only 12%. Civil servants scored slightly higher at 25%. Even if people are prepared to share sensitive information with other health professionals, they may have their reasons for not wanting to share that same data with the state. Their concerns may be based on personal experience. Who are we not to respect such a wish, or to tell our patients whom they should trust? The Commission claims that it wishes to foster patients' autonomy, but it is hard to imagine a concept of autonomy that would deny patients the right to object to the use of their most private sensitive data. I hope we all agree that the worst case would be if patients felt discouraged from seeing the doctors out of fear that the confidentiality of their health data could be breached. Access to healthcare is a fundamental right in the EU, rooted in Article 35 of the EU Charter of Fundamental Rights. Can we make this right conditional on a person's willingness to share their data? I should also mention at this point that scientists scored almost as high as doctors in the above-mentioned poll on trustworthiness, coming in at 57%. We can infer from this that patients may indeed be ready and willing to share their data for research purposes. Why are we afraid of letting them decide? The Declaration of Taipei, adopted by the World Medical Association in 2016, calls physicians the primary custodians of confidential health information. Fully acknowledging the value of health data for research and the improvement of the healthcare, it warns that the major risk scenarios may not result from science, but from the commercial, administrative, or political use of such data, identifying an imminent risk of abuse from outside the field of medicine, commercialization, cost-cutting, and potential political abuse. The Declaration of Taipei demands that the willingness and trust of those donating and sharing their data be taken into account, while acknowledging the obligation to apply high standards of protection. These words are more relevant now than ever. As a physician, I must be allowed to respect my patients' individual wishes instead of presuming what is the best for them. Trust and acceptance also require implementing the appropriate technical means to guarantee security and resilience. Patient data should remain available locally in medical practices, even if the EHDS network or parts of it are down due to a technical malfunction or a cyber attack. Lastly, the EHDS will only find acceptance with patients and doctors if it respects the doctor's primary duty. Motivation and passion is to care for the patients. Doctors do not have the capacity to take on additional part-time job as a data suppliers for researchers, politicians, or developers of products and algorithms. 21% of all doctors in Germany are over the age of 60 and are likely to retire in the next few years. Medical schools in Germany cannot meet our national demand for doctors. While populations are growing older, qualified healthcare staff is getting more and more scarce. The average amount of time a doctor can devote to patients has steadily decreased in recent years. Transforming a conversation with a patient or an examination into structured, exchangeable, EHR-compatible data sets will take additional time in daily practice. But as a result, the EHR will contain valuable data for the patient, other healthcare providers, researchers, and other secondary data users. It is fair to say that feeding the EHR is the healthcare professional's contribution to making the EHDS work. Obliging doctors to deliver data for secondary use purposes, meaning purposes other than healthcare, inevitably takes time away from patients, and thus is detrimental to the healthcare system. Healthcare professionals must be exempt from such requests, and not only if they qualify as micro-enterprises. Building the EHDS is a collaborative process, and we are right in the midst of it, in an evolving discussion. Both the Parliament and the Council have suggested important improvements to the text, and more changes are yet to come. I am pleased that with the European Parliament and the Commission's, we'll have two key players on the EHDS file on this panel, but also two panelists representing those who will be responsible for making the EHDS work on the ground even after lawmakers in Brussels have moved on to other issues, patients and doctors. Thank you for your attention.
Well, thank you very much indeed for setting out so clearly what it is we are going to discuss and highlighting the key points of interest for us today. We are, as I say, having our panel discussion next. There has been a slight change to the lineup. My name's Jennifer Baker. I am a tech journalist based here in Brussels, and I'll be moderating the panel, putting the questions to our speakers. Luckily or unluckily, I have years of experience in covering GDPR, so hopefully I can bring some of that to today's discussion. We were expecting Ms. Raffaelli from the Commission, but she is unavailable, so we are delighted to welcome instead her colleague Maarten Darzil, Acting Head of the Unit on Digital Health and European Reference Networks from DG Sante in the European Commission. Perhaps, Maarten, I could get you to take a seat at the end. Unfortunately, Mr. Tuchel from the Parliament isn't available as he had a committee vote, but we have a woman who knows a thing or two about data protection, Birgit Sippel, MEP. Thank you very much for joining us. If you could take a seat. Anka Thoma is Executive Director of the European Patient Forum. Will be giving voice to the patient side on our panel here today. And last but not least, I am pleased to welcome Dr. Stefan Hofmeister, Deputy Chair of the Board of KBV. Thank you all very much for joining so bright and early this morning. Let's have a first round of a kick-off question and really try and tell me what your initial response is on what you think the impact of the implementation of the EHDS will have on that trust relationship between patients and doctors that Klaus spoke about. Martin, give us your perspective first.
Yeah, thank you, and good morning, everybody. It's a real pleasure to be here and present the Commission's thoughts and considerations with regard to the proposal on the European Health Data Space. And I listened with great interest to the opening remarks and cannot agree more that the trust of the patients in the system and in the future European Health Data Space is essential to enable us to achieve all the benefits. The proposal includes many safeguards, and we are very cautious of the importance of this issue. So the proposal includes many safeguards and safety nets to preserve this very important relationship between health professionals and their patients. So I hope that if you're asking, will anything change in terms of the relationship and trust between health professionals and patients? I hope the answer is no. I mean, the trust will be maintained. What the European Health Data Space will do, it will make the process of treatment and diagnosis much more efficient. It will save a lot of time and efforts of the health professionals from the tasks that are often repetitive and duplicating, for example, tests and interventions that have been done before, will avoid the need to establish again the medical history of the patient and the previous interactions with other healthcare providers. It will save time for the health professionals that they will be able to devote in the relationship and the questions of treatment and diagnosis with their patients. And there are a number of safeguards in the proposal that will enable us to do it. So that would be my high-level response. Thank you.
Thank you. I mean, Birgit, your initial thoughts on what this implementation will mean?
I wonder where I should start with. So first of all, let me underline that if we talk about digitization or even AI, there is in itself nothing only good or bad. It depends on how we use it. And talking about digitization and maybe even the use of AI, especially in the health data area, we have to understand that there is no sense in putting all the many data of all the millions of European citizens in a big black box, and everybody can pick and choose what he wants to use. You need, even for research and for production later, you need specified data. You need targeted data to come to a good result. So that's the first step. With all the questions that have been mentioned in the starting debates, I'm afraid they are not all tackled or even solved, nor in the Commission proposal, not all of them in the text of the Parliament. And I hope we will hear later about all the many safeguards in the text, but to be honest, if doctors, my doctor, is forced to give all my patients' data, all my health data into one kind of a system, what could be a safeguard if I don't like that idea? So I don't see a safeguard if there is only an opt-out, but first all my data are given into a black big box and I have no control who is using it, for what purpose, where are the data stored, who will have access, will it be my doctors from whom I look for treatment, will it be someone else? And even in the area of research, I very often hear, oh, it's good for the research against cancer. Fine, but research can be many different things. And I'm not joking. Maybe you start a research because wellness is also in the proposal. And in Germany, we have debates about embracing trees for your wellness. So maybe you could do research to what extent embracing trees is helpful for you. Is that why you want to give away all your health data? And I think the main purpose here is not to support patients or facilitate the work of doctors, which could be a good aim, to have all my data available if I change a doctor. But the main aim is to increase data availability, to increase, hopefully, maybe, the business model of pharmaceutical industry, for example. They are doing the research. They want to make money later from selling their products. So a lot of things need to be taken into account. And I also would like to make a final general statement. We were very happy to present GDPR, the data protection. And we even were saying this is the golden standard for the world. But now the Commission, sorry to say, is coming up with one proposal after the other, one act after the other. By the way, we are talking about acts, no longer about directives or regulations, so it's acts. And all these pieces of legislation seem to a little bit water down the principles of GDPR. And it may also be a tricky thing that all these data files are given to different committees having different interests. So I'm a little bit afraid we are watering down the standard of protection for data. And I also would like to highlight as a final starting remark, sorry I'm a little bit long, that already GDPR states that data need to be protected. GDPR already is talking about most sensitive data, where you even need higher protection standards, and precisely health data are defined as most sensitive data. So I think we have to be really more precise, more tailored, what kind of data is given to whom and why. And we also should really give more control to the patients regarding an opt-in. And if you are afraid patients will not do it for one reason or the other, but the same as for the opt-out, you need to give a lot of information to the patient, even convince them about the advantages. So why not do it even for the opt-in? But obviously, that's a task that companies and other actors are not willing to do. But I would like them to do the work instead of putting all the burden about knowledge, information, and things like that only to the side of the patients. Thank you.
Thank you. Well, from the side of the patients. Anka.
Thank you. Good morning. I would like to start with a short sort of sentence that comes directly from our consultation with our members. The European Patient Forum represents about 80 organizations, associations of patient organizations from across Europe. Some are national coalitions and some are disease-specific European networks. And what came out of our consultation with members about the European health data space is that fundamentally patients want to share their data for research. They understand that sharing that data is important for advancing research. They are happy to do that if it improves their lives or the lives of people with their condition. Not all patients, and not without reservations. Or not without reservations. There's always a fear about giving your most private information to do it. At the same time, we also understand that there cannot be scientific progress without amassing a huge amount of data to enable it. And some very surprising information can come from amassing all of that data. To your question, Jennifer, at the beginning, how can this affect the patient-doctor relationship? I think in the worst-case scenario, it doesn't change. In the best-case scenario, the existence of readily available data, of machine learning, of AI, of data-powered tools for doctors, it can improve that relationship. Now, the patient-doctor relationship is already subject to pressures such as time, such as the increasing need of healthcare, especially in the last few years, the increasing expectations, the increasing availability of information on the internet, and the continuing, health literacy challenges on the side of citizens. I'm saying citizens because, And then my third point would be that there is already an enormous amount of health data that we share. When I input a search into Google about some symptoms that I have a stuffed nose, well, Google will know that I have, I mean, no offense, Google will know that I have a stuffed nose. And then the next thing that happens, of course, I get cold medicines advertisements in my Facebook feed. You know, we already share an enormous amount of data. That data can, it's all health data. Stuff we put into our smartwatches, stuff we put into our apps on our phones. It's important to regulate it because creating a framework of trust is the only thing that can harness that information into something useful, hopefully research, hopefully healthcare solutions, hopefully products. And it's also very important because that data can provide information about the needs of actual people, what they care about, so that instead of innovation-driven health, we have health-driven innovation, if that makes sense. So,
Thank you. Stefan, your final, your opening thoughts with the final first round.
Good morning from my side. I'm very happy to be here. And I would like to give you two examples from my daily life as a physician, one more philosophical and one very practical. And at first I have to admit that I have four hats. I'm a physician, I'm also an administrator for public health or ambulatory care. I'm also a patient, and I'm a citizen. And I will try not to jump bases. I will try to stick with my administrative function here as good as possible, because otherwise I would compromise all of my other partners here. The two examples, the philosophical one. Since Hippocrates, it has been standardized that patients and doctors have a very special, unique relationship. And the foundation of that is trust, 100% trust. The second you as a patient cannot trust your physician or psychotherapist to 100% be confident about you, you will not tell them. And I worked as a flight servant for the German Navy, and our biggest challenge as flight servants was to convince the pilots that they could trust us. Because for a pilot, whenever they trust into us and tell us a physical problem, the consequence is grounding. It's like death to a pilot. So what they do is they avoid you, they go to other physicians far away, pay them cash, and get treatment. And you don't even know what they have, and they have accidents in the air. So I have had this problem, and it does change physician-patient relationship. In the military, that's necessary. Otherwise, there's no other way of doing it. But it compromises, and that's the answer to that question. Now, I often find, and you said this already, the discussion a bit almost funny, because as a physician GP, I worked in Hamburg in northern Germany. Of course, it happens that people move to Hamburg, and they come to you with, when they're new, with 2 stacks of information. The teacher, glasses, a double name, and so they come and say, here's all my information, doctor, and they put it on the table. And the first thing you do as a good physician is you take it away, put it on the ground, and say, that's okay, I may read through it later, but now I want to know, why are you here? Where have you been before? What's bothering you? You start working with the patient. And you're not starting to read all of the old information that the patient provides for you, because it doesn't help in that moment. So it's fiction that 20 gigabytes of information will help you. And I also work as an ER physician on a helicopter. If you have a motorcycle accident, you remember motorcyclists always had these little capsules here with all kinds of information of blood group and whatever. There's no time to read that capsule. If that's a polytrauma, you scrap them off the street, run them into the hospital, you give them 0 blood, and then you draw blood, and there's no time to read. So all of these examples are not good examples. Now, coming back to the philosophical question, since Hippocrates, it has always also been necessary to share information to improve healthcare. Of course, if you only treat one and you've only seen one, you know only one. So you need to see more. So there is a potential in sharing data, qualified data, but it's also very, very compromising for the relationship between physicians and patients, and it's a huge issue. Last information that I will give you is that we had a long and thorough discussion about organ donation in Germany just lately. organ donation. Now, organ donation is very digital and simple. If my organ fits someone and I have an accident and I have no organ donator certification, that someone is going to die. Maybe I was too lazy, maybe I didn't know about it. Now, the German parliament, after a long discussion, did not go for an opt-out in Germany. They stuck with an opt-in in this very touchy and digital subject, after a long democratic discussion. And here, with an incredible collection of medical data, sensitive data, we're talking opt-out as it was nothing. That's also amazing. So that concludes my statement.
Well, brief but strong and to the point, I think. Martin, let me come back to you again. You mentioned safeguards, and we're going to give you the opportunity to elaborate on what those are. But I'm interested in questions of how definitions like secondary use are going to alter the presumed right to privacy of a patient, and where you think the safeguards in that sense might be.
Yeah. No, thank you, Jennifer, and it helps me in a way, because I was going to a little bit suggest that we try. I mean, we've heard many points and many issues. I think we need to try to disentangle a little bit the issues, because I think it's important that the proposal is essentially based around two pillars. I mean, the first one speaks about the primary use of health data, so essentially the relationship between the patient and the healthcare provider, and the use of data for the purposes of diagnosis and treatment of that specific patient. And well, we have heard examples. I mean, for example, if the patient comes with confidence to the healthcare professional saying, "Doctor, this will stay just between us." If today this information doesn't go anywhere in any electronic health record, it will stay the same even after the implementation of the European Health Data Space. I mean, this will not change anything. If this is purely information shared just in confidence between the patient and the doctor, the proposal will not change anything. But what we have, and now I'm coming to the safeguards included in the proposal. The proposal clearly says that the patient will have right to restrict access to his electronic health records. It may be a general restriction. Basically, the patient may decide, I don't want to share my electronic health records with anyone else but my treating physician. Or it can be more specific. Another layer that is included in the proposal is that the member states will be able to define what is the types of information that are required by different categories of healthcare professionals. So, for example, there is no reason for my dentist to know the information related to my psychiatric treatment. And this can be, well, it may or may not, I don't know, but I'm just giving an example. So, so the member states will be able to restrict and define, the categories of data that will be potentially made available to different types of health professionals. And finally, we are still talking about health professionals and their access to data of patients. They are still bound by the professional secrecy. They still have the professional liability and responsibility, and this doesn't take it away. So if there is a health professional that is misusing his position and is unlawfully accessing the data, he or she will remain liable, and this doesn't change with the current proposal. So there are safeguards and possibilities with regard to the primary use of health data that will be, that will allow for remediation of all these concerns and will help to create the trust. Now, moving to your question on the secondary use of data, because I think they're connected, but separate and different. Here we are talking about the reuse of health data for purposes other than direct treatment or diagnosis for the patients. So this could be, and we saw these examples recently during the COVID pandemic times, public authorities or health regulators are in need of timely access to data to make informed decisions in terms of policy or regulatory decisions. These may be projects or examples of health research and researchers trying to advance and find new therapies or new technology in the area of healthcare. There, the process will be very, very strict and, again, with many safeguards. So first of all, it will be based on the applications that will be assessed by the new health data access bodies. So it's not a free bar. I mean, there will need to be an application. This will be reviewed by the public health data access body. If the decision is negative, there will be no way the potential data user will get access to any data. If the application is in line with all the requirements in the legislation, and the legislation will provide an exhaustive list of legitimate reasons for which the access can be granted, then a permit will be provided by the health data access body. But by default, the data should be made available in an anonymized format. So we are talking about non-personal data. Only in very exceptional circumstances, if this is duly justified by the applicant, and then the review by the health data access body confirms this justification, the data might be provided in a pseudonymized format, but then it's made available in a secured processing environment that will be the responsibility of the health data access bodies to provide these secured processing environments with no possibility for the data user to download or take away from that secured processing environment any personal data. So no personal data will ever leave the secured processing environment. So this will allow let's say the researcher or the health regulator to enter the secured processing environment, run their algorithms or do the processing they need, take away the results, the aggregated results, but no possibility to download the raw personal data related to any individual. So I just think it's important to make this very clear. I mean, the primary use of data for the treatment and the diagnosis, and there are these safeguards that I mentioned, and the reuse of health data under the supervision of the new health data access bodies in a secured processing environment, and with no personal data ever leaving the secured processing environment. Thank you.
Well, thank you. I mean, you've mentioned sort of technical security there that we must have confidence in, but not every patient is technically savvy enough. I mean, there is a risk that they say, well, you say that, but I hear about hacks in the media all the time. I hear about supposedly secure data being leaked. Birgit, do you think there is more concern with secondary use of data than with primary use of data? Do you make a distinction?
No, I think there is a problem in all the two areas. Okay. And I would like to come back to the first use of data in a doctor's. And I would like to come back to the proposal. If I come to a doctor, he first will read all the many information. There might be patients who only visit a doctor twice in their life, so that's a quick check on the data. But there might be others who are in need of a doctor regularly. So will you really look into all of this? And many of the information might not even be important for the doctor, even on a second, third, or fourth visit of the doctor. So nevertheless, saying the doctors already do not have enough time to get in contact with the patient, ask all the necessary questions, I think the solution cannot be overload the doctor with all the many information. We need the time for the doctor to ask precise questions to the patient instead of reading everything. So that's not a solution here. And regarding the confidentiality of the doctors, okay, of course, you might not put everything into any kind of a database, but who is controlling that? So depending on the national legislation, and it's interesting again, that again and again it seems we are increasing the cases where we do some regulation on European level, but in the detail we leave a lot of things to the national legislation. So why then call we a regulation? And having in mind that maybe persons are visiting a doctor not only in one country, but also during holiday on a business visit in another country, you cannot even rely on your national legislation regarding access to data. So how do we deal with that? And I'm not even touching upon the idea how detailed are the information that are given away from the doctor, and in what language, and how do you deal with that? So I think we don't have the solution for that. Regarding the second use for researches and things like that, I think if we want to have the trust of patients, it may be that the users, the researchers cannot go back to an individual person, but someone can. And how do we ensure, once again, that access is not given to that data? And why should anybody doing the research, you were talking about exceptions, having access to the real persons behind? So I think that's also something we need to know. And I'm a little bit surprised that coming from a patients' organization, a behavior of patients now is taken against the interests of a patient. Yes, it might be that some people are using any search machine to look for some information regarding their health. And I'm afraid most of those persons are not aware that their requests and that information they give into the net are read by anybody. They are not aware about that. They should be informed, they are not aware. But now this behavior, this uninformed behavior, is taken against them, saying, oh, they nevertheless do it. So where is the problem? Let's get all the data and let it be used by everybody. I'm really surprised that this is coming from a patients' organization. It shouldn't happen. And the behavior of people because of non-knowledge should not be taken against them. So I will stop right here maybe for a moment.
Well, if we had an e-privacy regulation, perhaps this searches might not
We
happen.
don't have it by now. We have a directive. And
Yeah.
unfortunately, the Council, the member states show no interest in improving the situation.
I mention it because I know you're involved here. And when we come to the other element that was mentioned, so for example, trackers or fitness trackers, again, those are already covered by GDPR. Let me come then on to the question of, there are different types of patients. There are, those who have chronic or lifelong conditions who perhaps have a more vocal representation when it comes to patients' rights. And then there's everyone who just, for one reason or another, be it preventative medicine or getting a vaccination, see their doctor. So in a sense, if we're all patients, is it difficult to quantify those who would opt in and would opt out?
Okay, so we're all users of the healthcare system, right? Some of us are occasional users or primary care preventative users, and some of us are not. When I'm talking about data sharing, I think it's quite different I think it's important to make that distinction between the commercial environment with which we share data now and an environment run for healthcare purposes by the governments we pay taxes to look after our health and fund our universal health access, which is the principle in our political systems. It's quite different. When I say that what comes from our members is that generally patients agree to share their data, I am talking about chronic patients, so more intensive healthcare users, who are the most, in this debate, patients are actually the vulnerable ones because our patients, my members, depend on doctors, on healthcare professionals. They depend on the availability of services. They depend on their governments. They depend on industry. They depend on manufacturers for having solutions. And in exchange for that, well, we pay taxes or we pay copay or whatever, right? And I think it's very important from that position to understand that intensive healthcare users don't necessarily feel like they have the luxury of saying, we want full control over how my anonymized data or our anonymized data is used for research purposes. If you're a rare disease patient, there's like 5 people like you in the whole of Europe. Your genome is flying around the world. This is a literal quote from one of my board members. Your genome is flying around the world. You say, here it is, do something with it, look at it. And it's almost impossible to anonymize. And they would still do it because this is the fundamental need of better health, of a treatment, of a solution that makes people function. So when I'm talking about a sort of secondary, the anonymized data, that is essentially a public good. It's not personal, it is not primary health data. It's important to make that distinction. It's not my personal data, your personal data, or a chronic disease patient's personal data, or a cancer patient's. Or I mean, I don't know, I have to answer if I'm a smoker on any insurance form. But it's not the same. It's not the same thing. And when we're talking about the de-anonymization, what I understand, and there was a discussion at some point that we had, we were asked, what if in a big chunk of data I'm doing some research and some previously unknown correlation between two conditions becomes known? Who should know about that? And how does the patient or do the patients who are concerned want to find out, want to be told? Who gets to tell them? How? And what process does the de-anonymization happen? These are important moral questions, and I think they have also an impact on the patient-doctor relationship. So I don't know, I went on a ramble, but anyway.
I was going to say, I mean, in a sense, I mean, you say it's not personal data anymore, but we can only say it's truly not personal data if we have absolute confidence in the security of that anonymization process.
Yes.
Now, to come on, Stefan, doctors work in different ways. If we wanted this data to be genuinely useful, in the way we're suggesting, wouldn't it have to be so-called interoperable? Wouldn't it have to be a series of boxes ticked in a way that makes all data similar so that we get over these, even as Birgit pointed out, language difficulties? Different doctors in different places have different ways and practices of working, different national systems. If you do all that to make it all, if you like, interoperable, is there a danger that you then actually use the clinical value of the data for that individual patient?
Thank you for the question, very practical question at the end of the discussion. I would like to address one of your very emotional and strong arguments for opt-in, because you were describing patients with needs that are willing to give away their data because they know it's needed to treat them better. I have no doubts that these patients would opt in. They would all opt in. Now, if you talk about rare diseases, that doesn't change much because it's not the problem of research. That could already be done now. If you only have 5 patients, it's easy to gather that data. The problem is who is going to produce medication because there's no market. It's just not worth producing something for 5 patients. So that problem still exists. Coming back to your question. And one last thing. Anonymized data. It's a while since I've done research, but when I did research, it was very important in medical research to know the sex, the age, where the patient comes from, and a lot more things. Now, all this information that you need to do useful clinical research is enough for KI or AI to re-identify a patient. Nobody can tell me anything different. And any statistics professor will say, yes, Dr. Hofmeister, you're right. So either you have this data or it's medically useless. So much about anonymizing. Now, the practical question that is important for us as physicians is, if I have a sodium or magnesium or HB value, that's not even that is standardized, not even in Germany, between the labs. We're working at it, so we might get it done within Germany in the next, I don't know, maybe 2 years. But in Europe, not at all. And I'm not even talking about the range, the value that is between different physicians. They have different views and different medical societies. I'm just talking about the NG per deciliter or milliliter or whatever. So if it's not standardized, you need translation tools, which makes things complicated. If you only have PDFs, my colleague, Andreas Gassen, calls it the digital Aldi-Tüte. It's a shopping bag. Now, if it's PDFs, it's basically useless. So, of course, we need standardized information. Now, for X-rays, we do have standardized information. We have DICOM. That's one single international standard. for the whole world. You all know about DICOM. That's how MRIs and CTs can be transferred into digital data and sent. The big problem with DICOM is it's a huge dimension. And in most regions in Germany, as digitalized as we are, you can't send those because they won't go through. It's better in other countries, but in Germany it's really terrible. So there we have a standard. It doesn't work. An ECG, last example. An ECG is voltage versus time. X, Y. Very easy and simple. Have you ever tried a Siemens ECG to be read by a GE ECG? It's impossible. And why? Because Siemens wants to sell Siemens and GE wants to sell GE. So if we don't solve this problem first, the information of an ECG is useless unless you print it out and then you send the PDF as scan, which wouldn't be necessary because, as I said, it's physically only voltage versus time. So any idiot could do that. So yes, we need standardization. That's the minimal standard that we need first. Vaccination, we need standards. So on the vaccine, there needs to be a barcode. Then the physician or the physician's assistant can just read the barcode, put the patient's card in, put it together, and you have an electronic vaccination record that could work in all Europe. Why can't we do it? The industry so far tells us, no, we can't put bars on those vaccines, they're too small. So people sit in the office and scribble those 12-digit numbers and make 2 mistakes while doing it, and they put it in your little paper vaccination pass, and that's where we are. And those things have to be solved first. They would be helpful.
Okay, well, we're going to have another round, but just already I'd like to get a sense of the room, whether people have questions for our panel. Can I get a nod of the head or a show of hands if you think you're going to have a question? Anyone? Oh, yeah, maybe 1 or 2. Yeah, okay. Okay.
Alexander.
Yes. Okay, well, we'll take a question, yes, and then I'm going to come back to Martin as well for more responses.
Yes, good morning. Can you hear me? Excellent. Alexander Jekyll, working for the German Medical Association, but also chairing the CPME work group on digital health. One question that hasn't been raised so far this morning is the cost. We had a conference only last Friday, and one of the main concerns was that the implementation will cost so much money that this is money that will be taken from somewhere else. So a health sector which is already under the strain of underfunding and also staff shortage will have another big issue. This is the cost. So I'd like to hear, especially maybe from the Commission and also from Parliament, what their ideas is, who's going to cover the cost. Thank you.
Thank you for the question. Martin, I was going to give you the floor next anyway to respond to some of the things you've heard on the panel. I suspect you're going to use the phrase national competency when it comes to costs.
Not necessarily. I mean, partly, but I mean, yeah. I mean, it's a very good question, but also it links to the previous points because I mean, the issue was raised: why are we leaving anything for the member states? Why are we regulating, not regulating everything at the EU level? And there, I want to be clear. I mean, we are talking, about the act at the level of the European Union. We need to respect the competencies division. So, generally speaking, primarily member states are responsible for organization, defining of their healthcare systems and financing of their healthcare systems. So this is why the proposal put on the table by the Commission is not, and I want to be clear about it, is not requiring a general digitalization across the healthcare systems in the member states. These decisions are for the member states. What this proposal is doing is, once there is a decision to process, for example, electronic health records in a digital format, in an electronic format, so that this is done in a structured and interoperable format, according to the EU-wide requirements. And in that way, we are addressing the issue of, I think we don't need to go as far as talking about the cross-border interoperability for the moment. Today, it is difficult to transfer a simple data between 2 hospitals in the same city, and I'm speaking from a personal experience, it is true that there are currently issues, and the European health data space will not be will not happen overnight. We will not solve all the problems overnight. It is a process. The implementation will be a process. But what the proposal, and I didn't mention it in the beginning because I thought it's obvious, but one of the benefits that this proposal will bring is the European electronic health record exchange format requirements and technical specifications at the EU level. You know, slowly, I hope rather quickly than slowly, but I mean steadily, I mean converging and all the requirements and moving towards interoperability, and the data in a structured format. So, for example, there was a question, what happens with the translations? I mean, for that, we have solutions already. For example, in cases of cross-border healthcare, we have a patient summary, which is shortened version of the electronic health record. And because it is provided in a structured format, the translation is very easy. I mean, so the doctor can get access to the information translated to his or her language. Now, coming to the question, I'm not moving away from the question on the cost. So the decision to digitalize or not is with the member states, and it's clear that there will need to be an initial investment. But also the impact assessment that we have done on the proposal clearly shows that there are very important benefits of implementing the European Health Data Space, not only in terms, let's say, of convenience for the patients or advancement in research and new therapies, but also in economical terms, that in a medium term will outweigh the initial investments. And yes, the member states will need to play their part, but also we in the Commission are ready, to support the initial effort and investments. So we have already made available over 800 million euro at the EU level for projects and investments directly related to the European Health Data Space at the EU level. Plus, we have a much bigger amount of money made available to the member states, for example, from the Recovery and Resilience Facility, which the member states will be using for investments in healthcare, and especially in investments in digital health or digitalization of healthcare. There we are talking about an amount of over 12 billion of euro that member states already allocated for investments in digital health across the EU. Thank you.
You're shaking your head.
To be honest, listening to the Commission, I'm ever more confused. So if we don't want to interfere with national health systems, and if a national health systems would say, we have a strict confidentiality requirement for doctors, so the doctor is not allowed to share any information with anybody, we are out. So if that's the case, why do we need a European system? So we are doing, that's my impression, the second or even third step before doing the first step. So that's one point. Regarding the cost, to be honest, the Commission is claiming with its proposal, and some other actors are doing the same, that this is in favor of the doctors, but most important, it's in favor of patients. We are talking about the health of our citizens. Is that true? I wish it were true. But if we talk about cost, if we talk about who should get the data, especially for second use, it seems that this is much more in the interest of industry. We are willing to commercialize health data. And we should not forget that a lot of research is not done by nice NGOs interested only in the well-being of people. It's done by industry. And industry wants to make money. So if whoever is investing a lot of money in the European health data system to do research and produce better treatment, hopefully in the end, I think there will be pressure coming from that, from the industry, from those who are willing to use the data to make available all the data. So to that extent, the second step that we are doing will impact on the first step if we want to do it. I also haven't heard any argument why we should be in favor for an opt-out instead of an opt-in. Those who are really interested and see that they could have a personal benefit, or their friends or family members could have a personal benefit from it, they of course will do an opt-in. And if you do need an opt-in from others, once again, please talk to people. and not do it the other way around. We tend to have a tendency, to put all the responsibilities about knowledge, getting information, taking decision on individual citizens, and in this case on patients. And this can't be true, and therefore we have to be really careful. And when you talk about the European money for supporting this system, I'm always surprised to hear, looking at the big amount of European budget, for what many purposes the budgets will be needed. So I'm afraid the money will not be enough, so member states have to invest in it. And once again, maybe industry will also be happy to contribute to it. And this also shows who has an interest into all the data.
Well, Stefan, to stay with this follow the money, if you like, theme, I mean, let's talk about resources. For you as a clinician, I mean, presumably a certain amount of digitalization of records and so on is beneficial in terms of freeing up clinicians' time. Where do you feel the emphasis on resources should be?
Well, I think Klaus already outlined very well that we have a shortage of medical professionals throughout Europe. Not only physicians, psychotherapists, but nurses, PAs, you name it. So the focus must be on those with their special education, using all of their time treating patients and being with patients, not just treating, but listening to patients, interacting with patients. I think that's number one value and goal. Now, from a practical point of view, as you're saying, a physician, and that also is, I'm missing that in the discussion, at least in Germany, has always had not just the right, but the duty, the obligation to keep records, very close records on anything he or she does. That's a legal requirement, and you must have it when you're dragged to court. If you don't have it, it's already punishable just for not having it, even if you did everything right, because you can't prove it. So that has always been that way. It has always also been that way in Germany, that a patient is entitled to a one-to-one copy of everything that you've recorded. So far, it's been paper copies. The patient had to pay a very small amount for the copies, but he or she was entitled to everything. That's always been that way. Now, in a digital world, if I digitalize my documentation, which I already have in my office, if it's an upload, a push system, the patient tells me when we're ready and says, I need my data, I want it sent to YouTube or whatever, I don't care. You know, it's that logical second, I will, of course, give all of the data I have gathered from that patient to the patient. And the patient, and that's why I'm saying I'm not trying to change hats here as an administrator, I'm saying it's your data, you're entitled to it. Now what you do with it, whether you want to donate it to the industry or to research or to whoever, that's your business. As a patient and citizen, I have a view to that. But as a physician, I would say if that's the way, technically, no problem. It takes not even a second. When the patient leaves my room, he or she can say, I want my data in my electronic records. I push the load up button and the data is gone. And the patient is responsible for the data. If it's done that way, technically, from a physician's point of view, from an organizational point of view, I have no problems. I have addressed my concerns with that, but technically and as a physician working, that could be worked out.
So it's not a digitalization problem, it's an access question that we're debating here.
Well, I need my primary documentation for legal reasons. I don't want anyone to compromise that. I don't want their ideas of not gathering the data in one big server, but leaving it in the offices and having a grabber, that's what it's called, asserting and collecting the data, that's a scary thought. So I want one copy for me, my original, and I give one copy to the patient if that's what he or she wants, no problem. If it's just an upload thing, it will not take time. Technically, it's okay. It will not take away from patient-doctor time.
Anke, let me come back to the question of, well, first of all, the idea of commercialization of patients' data. You're saying that the feedback you're getting from your members is we want to share because we want solutions, we want cures. Is there any mismatch between that and giving the data to to put on my devil's advocate hat here, big pharma that we demonize all the time and say they're going to develop a cure, but then they're going to sell it back to you at a hugely inflated cost as a patient. Is there any concern there about where and setting the tiers for what can be done with that data, even if it is all in eventual search for therapies, for treatments, for cures?
Commercialization, yes. Look, it's a very good question. Can I just add in this question of cost that I'd really like to see some mention of investment in digital and data literacy. I was coming to that. Just because it's really, really important. And I think there's a lot of misunderstanding of what health data is amongst not in this informed, but in the general population. A lot of people wouldn't necessarily know, they wouldn't understand, and anyway, so that's the first thing. When it comes to commercialization, we are not in favor of commercializing health data. Nobody would. Now, I said earlier, health data, or for secondary use, the anonymized, the big data, has to be a public good. It's a public good. That is the premise under which patients would be happy to share. I'm talking about, again, the sort of chronic patients, our constituency, but I would certainly hope that would apply to citizens in general. It's a public good, and we want it to be used for good, and we want some reassurances in that. And because we started talking about trust, I remember that one of the things that I didn't mention is that for us, there are 4 elements of trust. One is the transparency of how the data is used and the availability of the results of the research for the public good, again. The second one is the participation of patients, and thank you for inviting us, and thank you for the efforts to interact with patients and work with us. The third one, as I mentioned, is the investment in health literacy. And the fourth one, because Mrs. Zippel asked, why do we support an opt-out? The fourth one is a possibility to have a clear and simple and accessible opt-out. That's because data quality relies on quantity of data. You need to collect as much as possible to make it good. But it's true. An opt-in system would create inequity due to the different levels of data literacy. And unless all of this can be fully aligned, you risk having data sets that are unequitable, they're not representative, they're not diverse, they ignore people from different socioeconomic or ethnic backgrounds. I mean, you can have a whole lot of problems. Some of them are societal and equity-based, some of them can be molecular. And all of these can affect the quality of the results. Finally, again, when we're looking for cures, I was saying the patients are the vulnerable element in this bit. Wherever the cures come from, we're grateful. And that's the fundamental, perhaps naive belief in the power of public good. There.
Okay, quite a lot to unpack there.
Yes.
Well, obviously, I definitely don't disagree that if marginalised or societally disadvantaged groups are left out of research, that is to their detriment. But on the flip side, you can't therefore say to them, you must be obliged to take part in research. Surely the onus is not on those groups of people.
No, but we do ask that there is patient and citizens representation in the governance of the European health data system at national and at European level to have that additional scrutiny of informed, trained, organized patients. Now, do I want a perfect democracy of 400 million people? Yes. Is it technically possible in the current system we have? That's maybe not for me to ask. But we ask for representation in order to have that scrutiny and to give some assurances. It's an element of trust.
Stefan, I saw you shaking your head, so I'm guessing you don't agree that more data is always better. Hence this continual question around opt-in or opt-out.
Well, that's maybe leading too far, but just a week ago we had installed a new leader in the Institute for Quality and Economic Value in our healthcare system in Cologne, the IQWIC. It's an independent institution, and its only goal is to do what the title of the institute says. And the keynote there was Professor Meyer, and she was addressing intensely the problem the modern believe the golden calf of real data, and basically ridiculing the real data, because that's not how research is done. It's not gathering a huge amount of data, shaking it, and looking what comes out. That's very rare that this brings progress in science and in medicine. It occasionally, there may be the lucky punch, but that's not the way it should be done. And there's a huge risk in gathering data, as we've heard. So for clinical research, as I said, anonymized data is problematic, and just a huge amount of data is also problematic. We have this funny research in Germany about the population of storks. And you know, in Germany, the children or babies are brought by storks, and the regression of the number of storks was correlated to the drop of the babies we had. So that proves the stork brings babies. That's science, because the data will give it to you. Of course, that's a bit ridiculous, but the example is there, and it's been used quite often for explanation. So I'm not saying it's not important to gather data. I'm absolutely with you that we do need to share scientific data for research. And we need to do more for rare diseases, which is not a problem of gathering data, but it's a problem of inventing medicine because you have no market to sell them. So that needs to be done by public money. There's no other way. You're not going to find anyone in the commercial industry producing medication for 10,000 people. It's just not worth it. So that's a big issue. But I don't think it's solved by just gathering data. So we should look into the benefits. There are benefits. There are benefits in digitalization. There are benefits in medical research if you have good, qualified data, standardized data that you can exchange. That helps a lot, and that can be useful for progress in medicine. But there are downsides, and they have to be weighed, carefully weighed. And I'm not so far seeing that the careful weighing is taking place properly.
Okay, do we have any more questions from the floor? We've got our microphone people on the... Yes, we have over here.
Good morning, and thank you very much for the very interesting discussion. I'm Shahar Adash, I'm the Secretary General of the European Doctors, CPME. I've been listening very carefully and also wanted to pick up just to start with one remark made by the Commission already several times, which is that this is not going to force anyone to digitalize. We hear you, then we also hear the billions of euros that are going to have to be invested at national level, and it's very hard to imagine that member states will be okay with this being used for the few hundred cross-border patients every year. So our members really believe this will fundamentally change the way they work on a daily basis. And I think it's important to recognize that this hits a workforce that is really in crisis in many countries. You can see this in the news. But I think that it's very important to see that everyone comes with this immense burden at the moment, plus with the experience of many digital reforms gone wrong. So I think this is very important to see that we do see the potential, but we do also know that it takes a lot of time and a lot of discussion to make these things go right. So we see a couple of very essential points. To go back to the legalistic text of the directive, we see really that the burden on doctors has to be proportionate, so that we have to exempt not only micro but also small entities that have to deal with this, to ensure that we do not burden sort of very small practices with this effort. Also, the point on investing in training needs to be taken into account. So this will really, at the practice level, also incur costs, and also costs in time. Past digital reforms have usually shown that it slows down the pace of work rather than improves or quickens it. And lastly, and this is my question, there's also the dimension of the medical EHR not being just a medical tool, clinical tool, but also being a legal tool. So how to ensure the data quality and how to ensure that in the interface that doctors will be using, it is very clear what information comes from doctors, what information comes from possibly patients. And of course, there's this whole discussion, which has really blown up in the last weeks around apps, how to make sure that it's very clear what information in this file is entered by a professional, which professional, what was available at what time, and what information is derived from other sources. So that would be my question. Thank you.
Thank you. I think, Martin, I'll let you respond first, and then we'll discuss maybe questions around liability. And
Okay. Thank you. Thank you for the question. I wanted also to come back very briefly on the opt-in and opt-out issue. So maybe I'll start with that, and then I come back to the issue of the information that is not inserted directly by the physician. On the opt-in and opt-out, I just because I didn't mention this before. I want to be also clear on that. The reuse of health data based on consent of the patients is a perfect possibility today. It will be a perfect possibility after the European Health Data Space proposal is adopted. So if we just reiterate in the proposal that we reintroduce the opt-in mechanism, there will be no added value of the proposal. So that's why it is not in the Commission's proposal. The reason why we are proposing the system that I described with all the safeguards is that currently there are two main issues. I mean, one is basically the feasibility or the burden that is imposed. I mean, collecting the consent, processing the consent, then potentially the data subjects withdrawing the consent later on. It makes it very, very difficult for especially large-scale projects and reuse of health data. And this was the feedback. Those were the challenges that we identified in the preparatory work. That was the whole reasoning for developing the proposal. The second reason is the representativity of the data. Again, if we have a specific rare condition where a majority of the patients will consent and provide their data, there is no problem. If we are talking about large-scale projects where large majority of the patients will not provide their consent and their data, that this may bias the results of the research, for example, or of the decisions of the health regulators. We are also talking about the public authorities or regulators taking the decisions, as we saw during the COVID times. And it is perfectly in line. It's fully in line with the GDPR requirements, because the consent is not the only legal basis for processing of personal data. There are a number of other potential avenues. So I just wanted to make a short remark on that. With regard to the data in the electronic health record that will not come directly from a healthcare professional, the proposal clearly requires, it allows for this possibility, for example, for patient to insert certain additional data if they so wish, but this needs to be clearly separated and distinguished from the data that is introduced there by the healthcare professional. So the patient or nobody else will have a possibility to modify or amend the information that is let's say the core part of the electronic health record that was introduced by the health professional. There might be possibility for additional, information from other data sources, but it needs to be clearly indicated as additional, and then it's, for example, for the treating physician to take it into consideration or not. So it might be useful in certain circumstances for the treating physician, but it needs to be very clear for them that this is information coming from the different sources than the healthcare provider.
Very good.
I have to come back to my initial statement saying that digitization in itself is nor good nor bad, but we need to take a concrete decision. What kind of data are we using for what purpose to make the best for our citizens? Now, I'm a little bit surprised to hear everything is totally in line with GDPR because consent is not the only reason to share data. I wonder what we are talking about. That's true, consent is not the only reason, but if in the end, for every kind of data, we are creating legislation, for example, on national and or on European level, the different kinds of data, of course, have to be shared, so we can forget about GDPR, if that's the other way round. I also would like to go into this question of data literacy. Of course, people should be aware what's happening and what good use or bad use could be made of their data. But once again, there is also a public responsibility on how to deal with data. GDPR is there, but it's not enough to state it's there. You have to describe in every single area what it means. And I'm sorry, but my health data are not a public good. Water should be a public good. Everybody needs it. Health should be a public good. Everybody deserves to have health. But health data are sensitive data that need to be protected. By myself, knowing how to deal with it, but also by my government, by public authorities, to ensure those data are not misused. So it's not a public good, my personal health data. And when talking about the possibility of opt-out or opt-in, I still haven't heard any argument for an opt-out. I'm sorry. And it's a little bit funny to hear, oh, it's easy to opt out, but first my data are exchanged maybe. But we need a quantity of data. So obviously there is not real an interest to see that maybe many people will not like to share their data because we need a quantity. And once again, if there is a serious need to share data, I'm convinced people will agree. If there is a serious, important improvement regarding health, no doubt about it. But my impression is, what are the products that are produced by industry with health? I think every year, those who might know better should interrupt me, every year we see new medicine in case you have a cold. Sorry, you may stay home for 3 days, that's also helpful, but every year we see new products regarding treatment of a cold, because this can be sold. People are buying it for what reason ever. I don't see many other medicine created for that. So still the interest of industry is there, and if my data will be used for such, sorry to say that, bullshit, of course I will be against. And once again, if we want to use health data, fine. If it's for the interest of the patients and for their health, fine. But we need to do it more tailored, more precise, and we should not make our life easy, saying, oh, it's on the patients to take a decision, and maybe they should have more knowledge. There is also a public responsibility to ensure this.
Okay, do you want to add something?
Yeah, I just, of course my data is, or your data is not a public good, mine is. But isn't it a public good to know how many patients with, say, cardiovascular disease are on a certain treatment and how they are reacting and aggregate that data? That was essential data, for example, about the safety of vaccines, of the COVID vaccines. That is a public good, presumably. That aggregated data is a public good. My personal health information belongs to me, and patients definitely own their personal health information. But when all of that is put together in a health system, that should not be commercialized. That's what I said, just to clarify, and I'm sorry for not being clear before. The opt-out for us is a mechanism of agency. An opt-in, I think the GDPR provides enough consent tools to do it, I presume. The reason we prefer to have an opt-out is precisely because of that aggregated general population data. And honestly, I would be worried less I'm going to be a bit controversial here. I think the danger in this does not come from big pharma, but from big app. If you're talking about the risk to privacy, it's not from medical products, I think. It is from apps that we all have on our phones and computers. And so if there's a risk, I think it rather comes from that side. Well.
Okay. I know we've got a limited amount of time and a couple of questions we have here from the floor.
Hi, my name is Philip. I'm from the European Public Health Alliance, EFA. So I heard this comment several times now that there hasn't been a single good argument for the opt-out. And as someone who now works for an NGO and who's previously worked for 2 years as a research assistant at a research university, I can definitely tell you that the quality of research is impacted highly by the representativeness of the data. If like going for an opt-in model ultimately creates selection bias, people who are more trusting of the government are going to be opting in and providing this data. I mean, we already have issues in terms of discrepancies between efficacy of certain drugs in clinical trials versus the efficiency in the general public, because even in clinical trials, which are considered the gold standard, randomized controlled trials, which are considered the gold standard for representatives of data, even there we don't really achieve full representativeness in terms of the types of people that don't really reflect the society that's going to be using the medication. And so yeah, so going for an opt-in is ultimately going to create that bias as well. At the same time, I also see the ethical issues of using an opt-out model when more than 40% of EU citizens lack even basic digital health literacy, because requiring someone to make the decision for themselves when they're not even literate is it kind of takes away from from the ability for them to be able to make an informed decision. So I definitely understand that, and that's why I truly believe whether we go for opt-in, opt-out, whatever, there needs to be big investments in digital health literacy, because informed consent can only be obtained if there's an equal footing between you and the person that you're asking consent from. But definitely, not only that, there are also concerns with that, with more and more use of artificial intelligence in healthcare and machine learning, if they are trained on data sets with an opt-in model, which are not representative population, then we're going to be creating and perpetuating more and more bias in the healthcare system, because we're going to be using data that's usually available not from vulnerable populations, not from minorities, but we're going to be using algorithms trained on that data and to apply healthcare provision, healthcare triage, personalized care to people who might not fit those specific characteristics.
I think
so there are a lot of dangers there.
We really are running short time. I think Stefan probably wants to respond. You've presented a rather dystopian view of the future, which I think probably argues against the use of AI on unusable data sets, rather than saying create more data sets. But
Thank you for the argument. I was hoping for it, and it's good that it comes from a researcher. Yes, there is a bias if you have an opt-in system, but and you were explaining it, the same bias with an opt-out system, because who's going to opt out? The ones intelligent enough to say, I'm not going to share my data, the ones that maybe don't care but are just a bit skeptical. So you also have the same bias the other way around. So that's a bad argument for either or. We should think more about it, how we should do it, I think, but that's a good argument. And coming to the other question, and also I wanted to say to the Commission, you were saying we already have a system where you can donate all your medical stats to science or industry, whatever, and that wouldn't be a change. But to me, digitalization is sold as the quantum leap in research. So already the digitalization should be that big step, good enough without opt-in or opt-out. So if that's not the case, I'm not I don't understand what we're talking about. So I think if we had a good digitalization, it would be helpful for clinical research either way, but there would have to be many checks and balances, and that's also not an explanation for opt-in, opt-out. Last thing, liability, because that concerns physicians. I had the opportunity to visit an American system at the West Coast, I'm not naming it, where physicians and patients all have an electronic record and everything is recorded. Besides the fact that there's a dashboard for the CEO where the CEO sees everything that's done every day, every minute, and can control the patient as well as the physician, which is spooky for me as a physician, but that's the way it is. There's another fact. The number of treated patients by the physicians in that huge American healthcare system has dropped to half after introducing the electronic record. Why? Because now the physician has to read everything that's in the record for liability reasons first. So that was like the patient that I told you about coming to me from another city and unloading 2 big stacks of information. Normally I would say, go away, come back in 2 weeks when I've read this, and then we can talk. And that's what happened there. So they've reduced their productivity to a half, and they're now working on how they can return to a better turnaround in physician-patient time. So that's what happened there. So that has to be addressed also. Am I obligated as a physician, if somebody comes in and gives me 50 gigabyte of electronic record, to go through that first? And am I going to be sued because on page 5,329, in the last sentence, there is some information that I could have used to treat the patient better? Or am I only obliged and obligated to do what I've always done, ask the patient, what leads you to come here? What is your concern? I will physically examine you, I will do my tests on you, I will run through everything with you, and then I will come to a conclusion. And that's something that so far, and as far as I know, has not been solved yet, and that's a big, big issue before we have an electronic health record.
Okay, last question from the floor here.
Joel Girard, representation of Hessen. I think we have seen that the electronic health data space is the most controversial file on technical, pragmatic, and ethical points of view. I have a question, perhaps because we see it's also on personal perspective. I found like a kind of Belgian solution on my Belgian resident card. I do have an electronic health data sheet. On my German insurance card, I don't have. Perhaps because I think there are risks and opportunity linked intrinsically. So wouldn't it be easier perhaps also to separate the discussion of the health data record of patients and the research question, because we all see perhaps also benefits more easily on a personal health data record, but have perhaps more reservations on sharing our personal health data in a space for research, since we are talking about pseudonymized data, but we all know that the DNA is the best unified identifier we know so far. So would that perhaps ease the question, because we have to balance a lot of difficult questions? So to separate those two strands, would this be perhaps a step to make it easier to find a solution?
Anyone want to tackle that? Yes, Birgit.
I would like to come back to that question, making differences. And to be honest, following the debate today, I have the impression that generally talking about health, so talking about serious diseases, but also about wellness, in itself is creating concerns. What are we really willing to do with all the data? We are not targeted saying we want to improve this or that situation. And therefore, I think my concerns regarding this proposal of the European health data system even have been increased through the debate today. And to that extent, I have some sympathy to say, should we first talk about having a digital record and then have a separate debate about sharing data, and also about the question, what is my responsibility? What are the needs for real research on the most important things, not on wellness, coming back to embracing trees, I don't want that, and be more specific. And so to that extent, I'm afraid we need some more work to be more precise what really is the aim of this proposal, what can be reached in short and longer terms, because with this, we might not meet the interests of all the patients, and we might not even meet the interest of research, because if you want to do researches, you even need the correct data. And I'm not sure that with this proposal we can make sure already now at this stage that those who are doing serious research will get really the precise data that they need to be effective.
Stefan, you wanted a very short response.
I would try to tackle the question. Yes, the first step would be for every physician, psychotherapist, and medical health professional to have a digital record, which in Germany all physicians in our system have, and then have digitalized, standardized data. That would be the very first step between me and the patient. I have the original, the patient may have a copy, of course. And from there, the back door could be the patient can opt in or opt out, we haven't finished the discussion, donate the data for research, either to the government, to university, or to industry, or to whomever. Those would be the steps. And I don't think there's a question in the usefulness of good clinical digital data within my physician's office. That's where we need to go, and we need to standardize that data. I don't think there's anyone who could object to that. Hardly anyone anyway.
Okay, right. Well, we're at the final. I'm going to ask you each for like a 30-second summation, which I know is difficult in a debate as nuanced and complex as this, and I know we could have talked about this for another 2 or 3 hours and still possibly not solved all the problems. But the final question I had here is, if you'd one wish, which measure should be prioritised in the implementation of the EHDS? One measure, Martin.
It's not the measure, but I think what I was also, I mean, it was very interesting, intense discussion today, but I think we always have to bear in mind, I mean, the European Health Data Space is not the ultimate solution. It's a tool. It's a tool, and we need to bear this in mind, that this is a tool that will be put in the disposal of the clinicians, health professionals when treating their patients, and in the disposal of health researchers or health authorities when doing research or taking informed decisions. So I think we need to bear this in mind. This is not a solution in itself, but a tool or means towards providing better healthcare for all. Yeah.
So it's a tool, not a full solution. Birgit, a quick 30-second summing up from you.
I would like to have more pragmatic ideas and solutions to improve the situation of doctors and patients, meaning that doctors need to have more time for the individual patient to really look into the situation, and based on this, develop further the ideas on the European health data system, and maybe we should take more time for this second part.
Anka?
The priority in implementing, better and more consistent patient participation in the governance of the system, if we're talking about the implementation. And secondly, significant investment in health literacy.
And finally, Stefan, I'm sure you're not going to say no to significant investment.
On the one hand, since the issue is huge, I would ask for more time and thorough discussion for the legal, the moral, and the technical questions. This is nothing to be rushed. On the second hand, the one big thing I want is standardization. And that needs to be done by legislation, because the industry will never standardize, because it compromises their business model. Standardization, otherwise it's useless, because if I'm only electrifying paper, I have PDFs and I have a digital shopping bag.
Okay, well, thank you very much. Thank you all so much for your attention, and it has been a really interesting debate. Thank you to our audience for following along online, and of course this event has been recorded, so if you missed anything or there was too much nuance too quickly, you can go back and listen to it again. And remember, if you want to continue the discussion on social media, do use the hashtag EHDS and hashtag eHealth. Thank you once again to KBV and the German Medical Association for organising. And finally, a big round of applause for our panellists.